Welcome to Bostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Well, hello and welcome back to another episode of Bostic Health here in the wild. We're at ViVE, recording live from the exhibit hall, where I am joined by Aneesh. Thank you so much for being here.
Thanks for having me.
Aneesh is the former U.S. CTO, also has been an entrepreneur, and probably doesn't even need to be introduced, but appreciate you being here.
Thanks for having me.
So tell me some background on how you've gotten into where you are, having this opportunity to inform policy and really play bigger into trying to make healthcare better.
Look, I strongly believe in the public-private handshake. So where the government shakes hands with the private sector is an opportunity to tap the entrepreneurial spirit of the country, innovators, to solve some of the biggest challenges we have in the policy domain of access and affordability. I was asked by President Obama to serve as Chief Technology Officer, and my job on day one was to open up government data. And one of the most important data sets we released was the Medicare data set. By the way, if you're on Twitter in the last few days, you may have read about the fact that the Trump administration opened up the Medicaid data, and there was a lot of folks, data scientists on the internet, pouring through all the public data to see where there could be potential opportunities for detecting fraud. So that idea of opening up government data is actually a bipartisan idea that President Obama happened to champion in the creation of the role that I held. In my entrepreneurial journey, after leaving government, we started a firm called CareJourney, which ended up becoming one of the largest, if not the largest, commercial researchers on Medicare data. And that business helps to figure out who the highest quality doctors are for any given condition based on the evidence of how they treated patients, not on their Yelp reviews, so to speak.
Okay.
And that was sold to a firm called Arcadia, which has become one of the market leaders in population health management. And frankly, this new idea of an outcomes as a service platform where health systems, health plans can collaborate to focus on achieving an outcome, taking advantage of all of the open data and the emerging AI and agentic tools to take action to make sure patients get routed to the best possible place at the right time for the needs that they have.
So how long was that run from starting that business to when you sold it to Arcadia?
About 8 years.
Okay.
Life is about a decade. So if you cut it plus or minus, it takes about a 10-year journey. I'm sure your journey was the same.
Well, and they're like dog years, so it's really like about 70 web years.
You got it. And the Arcadia team gives me a second wind because they're also taking it to the next level. So I feel like I've gotten multiple bites at this apple, so to speak, of scaling a big idea and having impact.
Right. So within your role as the CTO for the United States, you said one of the initiatives was focusing on liberating the data, unlocking the value from the data.
That's right.
Has that been a pretty successful initiative?
Yeah, it's bipartisan. So the Trump administration is built on that. And what you'll find basically is it's now default setting. Transparency is the baseline good for us to make a difference in healthcare. Now, the challenge is how do we take action on the data that's being made available? And so that now is entering the AI era, where agents can interpret, not only aggregate the data, but help interpret the next best action. So we're going to start to see the unlock of what is otherwise today a more difficult process of sourcing the very data that we made public. And so that's an area that I think is going to be the next decade's journey.
Are you seeing some practical AI examples that are delivering on some of that unlock?
Oh, 100%. So let me give you a few examples. An academic medical center in the Southeast was pretty poor performing on their Medicare Advantage star measures, those quality measures, like the share of your population that has blood pressure under control. This is often the work of the long tail of patients that don't need the doctor's immediate attention, but they're slowly struggling in their performance. That's the group that you want to make sure has their A1C under control, their blood pressure. So they're using AI voice agents to make outbound calls to patients. And they're on, I listened to a call for 6 minutes. Hey, do you have a blood pressure cuff at home? Let me walk you through how you take your reading. This is what it looks like. And grandma and her family is working with her to get it done. And we saw this medical center go from like a 2-star performance, if you will, shadow numbers on their book, up to a 4-star, which is the kind of when the quality bonuses trickle. And they got millions of dollars of quality bonus within 90 days of just doing a better job of outreaching to the population that isn't in their practices every day.
Right. And this is a voice-based AI service that when the customer is contacted, they get what they need done. And do they know it's a
Oh, that's right.
AI agent?
Back to the point about standards and industry best practices.
Right.
Watermarking is something that the Frontier Labs committed to the Biden administration, and they're continuing to work on that philosophy. So this company who works with us called Guide Health, they actually took this responsibility on their own to disclose we are an automated agent on behalf of Dr. So-and-so calling to check in on you.
Yeah.
And by the way, UC San Diego wrote a paper in, I think, New England Journal saying that the patients actually felt more trusting when their emails were written by a doctor. This said, this message was partially automated and reviewed by Dr. X.
Interesting.
So this disclosure feels awkward, but actually turns out to be a more trustworthy action.
Right. Interesting. No, it's fascinating. I love it when we actually see the fruit actually coming to, there was all this hype and people would talk about AI is going to change everything.
Yes.
And then you'd say, well, what is it doing?
Right.
And they'd say,
I don't know.
I use it on the internet. Like, well, that's not actually the value. So these agents that solve these very specific pain points, I think, are extremely promising. So if you rewind the tape in your journey, your career, where did it start? Like, how did you end up navigating into this world?
I'm a child of the Bill Clinton era.
Okay.
In the 90s, I was at Johns Hopkins University. And if you had any interest in public policy, the issue of the day was healthcare reform. All of us dug our teeth into it. And I happened to be in Maryland, where the governor appointed the president of Hopkins University to be the chairman of our version of the Clinton program called the Healthcare Access and Cost Commission.
Okay.
And I said, hey, can I be an intern in the program? I was campus, whatever, class president and stuff. I got interacted with the university president regularly. He's like, yeah, come on in. So I just sat there as like a sponge reading everything that was happening at the time. And I was convinced that as we were to modernize, if we could get the incentives right and we could open up some of this information and use these emerging, at the time it was the internet, emerging technologies, we could really piece together something that's going to make a difference in people's lives. So that triangle, opening up the data, having some kind of incentive program to reward the use, developing sort of new technologies to interact with people, often when they're not in the clinic. Those things, that's a virtuous flywheel of, so I've been a dreamer of this moment. And I feel like I wish it was done a decade when I started. So by 2005, but now we're, 30 years later.
It takes a while.
It takes a while, but man, do I feel like it's coming now. I mean, I don't be the boy who cried wolf, like, oh, it's coming, but I think now it is.
Yeah. It's very interesting to hear that. My experience was sort of similar, although not in the political realm, but I was in the business of e-commerce when I was in college. I started a company and it was designed to personalize the experience for the customer. I moved into healthcare through working at Ernst & Young, doing consulting. And I could not believe that in healthcare, nothing was tailored to the customer.
No.
But I thought, oh, this will get sorted. Like, this is going to happen. And so I dove in, headlong to try to help solve it. And lo and behold, I ran headlong into this whole thing about incentive drives behavior.
You got it.
And I'll never forget sitting in the early 2000s with the CFO of a big health system and saying, hey, I can come in and with these concepts and technologies now with the internet and personalize the experience. And actually, in some cases, people you'll be able to identify before they even get hospitalized and blah, blah, blah. And she looks at me and she goes, if we do that, what will it do to my fee-for-service revenue?
You're right.
And I said, what did he say? And, I learned a ton through the School of Hard Knocks about what was or wasn't aligned with the incentive models. What is your view on the shift to value-based care, accountable care? Do you see that as a tailwind? Or do you see it as something that's just too hard to do?
It would be cute and easy for me to say, yes, of course that's the answer. But let me try to peel the onion back one layer so we could kind of have a more refined discussion. 10 to 15% of the population seems to be all in on taking responsibility for the total cost of care. On the margin, that number may move up, and we hope it will move up. But let's assume it's going to be at a slower pace than perhaps the pace of adoption of AI agents or other factors. Mm-hmm. What I love about CMS is that they have reimagined what an outcomes-based payment looks like. Today, it's actuarial math. You got a population, I'm going to put a price on the risk, and if you beat that risk population target, you get to keep a portion of the savings. Simple an idea, but man, to calculate that actuarial math fairly and accurately, hard. Gaming is there, all kinds of challenges. In the access model, where CMS has said we're going to completely reimagine what a care delivery unit will do, CMS said, hey, no more upcoding, no more micromanaging CPT codes. I'm going to pay you a base fee for every patient you've got enrolled in your clinic. And if you hit the outcomes goals, you get the bonus payment. Basically, that's it. No fancy, complicated, observed to expected actuarial math. So we're going to launch 4 chronic conditions as a country later this year. Metabolic disease, early stage, late stage, low back pain, and mental health issues. And we're going to see an entirely new class of physician clinic that cannot have one foot in the fee-for-service business, back to your conversation to your CEO, Fred, has to be all in on outcomes-based payment. And they're going to start small. But boy, oh boy, do I think my mom and dad in Medicare fee-for-service, they'll sign up for folks that are going to help them better manage their condition in between their doctor visits. And I think this is going to be wildly popular, and it'll be outcomes as a service. And that gives me hope that value-based care, in air quotes, will look a lot more like fixed outcomes payments for services that will be bundled to deliver that outcome, and almost like immaterial to the individual CPT codes of what you did. The inputs shouldn't necessarily be micromanaged towards the outcome. Let the outcome be the outcome. And if you could do it for a 90% cheaper way of doing it, God bless you.
Right. And then the bonus is bigger, the payment's bigger, the better that you're doing.
You got
that program.
You got it. Hit the results objectively, and off you go.
Right. No, that's very helpful. I personally think that incentive model is a good way to drive the right behavior.
Yes.
And I also don't think that fee-for-service goes away. It would be pretty tough to get to that point. But Medicare talks a lot about big shifts into value-based care.
Yes.
So how do we decipher that?
Well, you can't, in a voluntary world, I can beg of you, please come into my voluntary model.
Right.
But the math comes out to, if I'm going to go in it, I'll have my experts do the math, and we actually supply some of that math. So I've seen it in the real world, where like, hey, if I've got a high chance of winning because I've got a pretty good team, I'm going to go in. But I'm walking into a deal that I'm already underperforming in before I even start. Am I going to voluntarily sign up for that program? Probably not. So they call that risk selection for participants. So if CMS were to do mandatory models, which they've started with this team model, then you could start to see value-based care scaling.
Right.
But if we're going to stay on voluntary, we're going to have to kind of test and validate and learn what works, and then maybe scale in mandatory form that which is shown to be highly effective. That road will continue. We've been on that road for 15 years. Now we need a new additional path to look at value-based care. We haven't even talked about the employers. Employers would be a third path around AI-powered care navigation.
Right.
So there may be like several bites at the apple to call value-based care, where the entity is aligned. I call this a health information fiduciary, where the entity is aligned with my objectives as a patient, and together we're going to get to better outcomes, and then the math will work out for whoever's helping me do that.
Right. Health information fiduciary.
That's the market I'm hoping to serve in my life.
That's a good soundbite. So the future is probably much brighter than a lot of people think, but there's still a lot of work to do. But if you look at your crystal ball and you envision this future of healthcare,
Yes.
in our lifetimes, what do you think it looks like?
I'm a bullish, I'm a disciple of the abundance philosophy.
Same.
So today we constrain care management because it's a high cost resource. And so we have to tier it to the high risk patients. It's like job one of an ACO. Who are your high risk patients?
Right.
What if everybody got the same high quality service, hundreds of touch points a week, support and engagement whenever they're on demand, when they're ready for it?
Right.
So this whole concept of AI front end to kind of engage patients along their care continuum, maybe like a care protocol, where it's sort of like a Waymo style care protocol. Hey, you've got hypertension, you got these other comorbidities, this is the protocol, and the AI agent will work with you and escalate back to the doc if you got to come in to change your meds. We don't do that today.
Right.
We do high manual labor care management. So I see an abundance future, which means we're going to offer quote unquote value-based care to everyone at a fraction of the cost.
In a tailored model where you never have to repeat yourself, and there's all this insight into where you're heading with your health and predictive capabilities so that you get ahead of the curve.
July of last year, President Trump convened 60 major health organizations and big tech, OpenAI, Anthropic, etc. They committed that by March 31 of 2026, they would offer conversational AI tools in a secure lockbox that every American would have access to pull their records and have a vehicle to communicate. OpenAI and Anthropic shipped it in January without any new laws, with any incentives, subsidies, nothing. Now I can pull my medical records thanks to TEFCA and the programs that we put in place over the last 15 years. And I can put those records in a secure enclave within OpenAI, within Anthropic, that doesn't blend your data for training purposes. And I'm using it myself right now. I'm in Anthropic, and it is amazing.
Right.
I'm like, summarize my labs. What do I have to worry about? What's next on my journey? I now have a nice, pithy summary of my health status. Touch wood, I'm reasonably healthy, but it's still helpful to know. I'm brown, I got Indian mafia, so I got like a lot of cardiovascular risk. They've identified all the things that I need to be worried about. That's now. So this is nothing but a positive future, but what's it going to look like in 6 months? I can't wait.
Yeah, I'm with you. Well, I think that's really cool. So you have engaged in the service. Did you go Anthropic or did
I went Anthropic
okay.
in part because OpenAI has a wait list.
Oh.
So I pay for the $200 subscription for OpenAI. We're blessed in life, right? So we'll pay for these things. And so I just picked up the Claude subscription. And so I've experimented with the last couple of weeks, and it's been phenomenal just to help me make sense of all of the labs that I've had over the years and my annual wellness visits. And thank you. I'm grateful. I got it. And if I ever touch wood, need anything, I got a nice summary I can take with my QR code to the next clinic visit. And hopefully that doctor could just read it instead of me having to fill the clipboard.
Yeah. Well, I love that. I think that's a great place to wrap as we're here at ViVE trying to make healthcare better. Abundance. The future is much brighter than you think. It's a great way to live. And it's also something that there's a lot to look at now to make sure that we're reminded this is happening. It's not just all futures anymore. So thank you so much, Aneesh Chopra, for being on the show here and for all the fantastic work that you're doing to drive innovation into healthcare.
Thanks for having me.
And thank you, everybody, for being here at another episode of Bostic Health in the Wild at ViVE. We'll see you next time.